Do you know that today many Americans are caring for an ailing family member or friends? Many of these families, for the first time, are facing a serious, life-limiting illness. This can, of course, be overwhelming for both the patient and the entire family, especially if you don't know where to turn for assistance and support. What is hospice care? Who needs the services of a hospice care agency? In what manner are hospice care and palliative care different? For what period of time is hospice care usually given? In what settings can hospice care be given? Who pays for hospice care? How does one find a hospice care provider? What options are available to a family in order to care for a loved one who's nearing the end of life? Should families ask about advance directives, the Family Leave Act, and grief counseling? What are the common myths or misconceptions people have about hospice care? Hello, my name is Attorney Ramsey Bahrawy, and welcome to Your Money, Your Life. In this segment called ComfortCare, we will be discussing hospice care available from hospice care agencies such as All Care Hospice. To assist me in this discussion is Dr. Lewis S.Hays of All Care Hospice. Dr. Hays has been involved with hospice since 1982. In the year 2010, he became board certified in hospice and palliative medicine. Dr. Hays, welcome to Your Money, Your Life. It's great to have you on the program.
Well, thank you for inviting me, Ramsey.
Let's start with a little bit about All Care Hospice. What do they do, where are they located, and how long have they been in business?
All Care VNA, Visiting Nurse Association, has just celebrated our 100th year of existence.
Wow.
And about 7, 8 years ago, the VNA said, we really need a hospice, and out of that was born All Care Hospice.
All right. Now, you're board certified in hospice and palliative care. Could you tell our viewers, number one, how you developed this interest, and number two, a little bit about your credentials?
I actually had an interest in end-of-life care that began when I entered medical school. I did experience the death of my mother when I was in my junior year of medical school, and I recognize now how much better my family would have done had we had the support of hospice. I was a primary care doctor for 24 years, and throughout my time as a primary care doctor, I was integrally associated with hospice because I really didn't feel that I could practice good primary care and not be closely affiliated with hospice, given how important I feel it is at end of life.
Right, right. Now, oftentimes the phrase comfort care is associated with hospice. Would you like to comment on that and whether you think that that phrase is actually appropriate?
Well, the phrase comfort care really relates to when people say that all they want is to be kept comfortable, and the care should be directed to accomplish that. Mm-hmm. There is unfortunately the belief that many people hold that hospice is comfort care, and that in fact is not so. That in fact there are all degrees of hospice care. The extreme, if a patient and family says, all we want is to keep me or my family member comfortable, that's comfort care. But many people come on a hospice with terminal illnesses, for instance, people with chronic lung disease, and we know that they're declining and likely to die, but one of the problems they've struggled with has been recurrent infections. And we will treat those infections. Sure. So there are all degrees of hospice care. Along that same line, there's a lot of people have heard that you have to be a do not resuscitate. That is not correct. In fact, it's illegal to discriminate against a person because they choose to be a full code. So we take all comers. It's not uncommon people with cancer who are on hospice are receiving radiation therapy or chemotherapy if it's palliative in nature, and palliative meaning to alleviate symptoms.
Okay. Is there a distinction between hospice care and palliative care? And if there is, what is that distinction?
Absolutely. To palliate means to alleviate symptoms. Okay, so palliative care in its broadest sense means any care that's directed at alleviating symptoms. In this country, there is one defined benefit which provides palliative care in the ultimate extent. That is hospice. Okay. It's based on Medicare legislation passed in 1982. In this country, now more and more they're rolling out palliative care programs. The problem is there is no there is no reimbursement for any palliative care that's provided other than for a doctor or a nurse practitioner. However, to provide quality palliative care, you really need a team. You need to provide comprehensive palliative care, and the only way we can do that reasonably in the United States is with hospice, which requires that there be comprehensive approach to care.
When you say a team, what kind of team are you talking about?
Under Medicare guidelines, the minimum requirement is there must be a nurse, there must be a social worker, there must be a chaplain, there must be a doctor, there must be bereavement. That's the minimum requirement. Now, hospice requires a lot more than that, and under Medicare legislation, it's not okay to have a team in name alone. We're used to going to the hospital, and there are teams of people who are caring for us. There are the nurses, there are the aides, there are social workers, there are case managers, there are doctors. But a reasonable question is, how often do they all sit down in one room and talk about the care of any individual patient? And the answer is almost never. You're lucky if the doctor talks to the nurse. Well, under Medicare law, people who are getting hospice, it's required that a minimum of once every 15 days that every member of the team sits down in the same room and discusses the plan of care and how to proceed in the provision of care. So it truly is a team approach to care, and I think it's really important to make the point that hospice care is different than the health care most of us are used to, in the sense that it is family-centered care. So in hospice care, it's not a patient who is the focus of care, it's a family, because almost invariably people who have serious or fatal or terminal illnesses, there are people around them who are affected by their illness. And by the way, the definition of family in hospice is not blood relatives, but it's anyone within the circle of a person. The staff of the nursing home become de facto family members. Well, they are, when those people come on hospice, that staff should be allowed to receive or partake of the hospice care provided to that patient.
How does someone know whether or not they need hospice or palliative care?
Palliative care, again, is anybody who's got symptoms that are not well controlled. Symptoms are managed very poorly, and palliative care is about symptom management. Hospice, as defined under Medicare, and the definition that we have to apply to an individual to determine if they're hospice appropriate or not is with the usual course of their illness, are they likely to die within 6 months?
I see.
Okay. Now, it's interesting, when the legislation was first passed, it was with the usual course of the illness, they would die within 6 months. And then the government said, holy mackerel, that's really going to pour cold water. You know, what happens if the person lives for 6 months and 1 day? That's Medicare fraud. And so they quickly changed it. Now, that 6 months time frame is important because many people, therefore, believe that hospice care is limited to 6 months. And in fact, that is not so at all. It's an unlimited benefit. Okay? When people come on to hospice, once they come on, it's determined they're appropriate. 3 months after they come on, the medical director of the hospice that's caring for them must reassess them and decide whether, in fact, they still remain appropriate to remain on hospice. And what they're looking for is decline from the time they came on, you know, in that 3-month time period. If they still meet the criteria, then they have another 6 months, so you're out to 9 months. At 6 months, there's another recertification, and thereafter every 2 months. And as long as we can demonstrate decline, people can stay on hospice.
So let me follow up on that a little bit. So if someone who qualifies for hospice is someone who's looking at a death 6 months or beyond down the road, does hospice care actually help extend somebody's life, or does it not?
Well, that's a great question. It's a terrific question. The common, again, widely held misconception is that people who come on hospice tend to die more quickly. And so people will say, when they're referred to hospice, oh my God, am I that sick? You know, do I really have one foot out the door? In fact, what has been shown conclusively now, the group that is referred to hospice virtually always lives better. And secondly, there's very convincing data that, at least statistically speaking, they live considerably longer. And probably the earlier they're referred to hospice, the more likely they accrue that benefit. So in fact, this idea that hospice somehow shorten lives is completely untrue. It's really the opposite.
You know, I have some personal family experience when it comes to hospice. My father was suffering with cancer, and at some point his cancer metastasized. And my father's reaction was, you know what, just make me comfortable, let me have some quality of life. And he was referred to hospice. And outside my father's hearing, I was basically told by the oncologist, you know, he maximum 3 months to live. Right. Well, my father ended up living over 5 months. And we really believe that was because of hospice, because he had that care. And he did have better quality of life, no doubt about it.
Yeah, there was a study that came out of Massachusetts General that was published just about 2 years ago in the New England Journal of Medicine. What they found was the group that was required to meet with, not to do anything based on the recommendations, with the palliative care hospice team, ended up living 28% longer than the group that was not offered the hospice / palliative care, and they also live statistically far better. Right. So that this idea that what we all look to, the bells and whistles that American medicine offers. In fact, this study is a very different message, and the message is that making people comfortable, okay, addressing their symptoms. People oftentimes choose not to have chemotherapy, radiation therapy.
Wow. Hospice, can that be given in the home? Can it also be given in institutions? How does that work?
When the Medicare hospice benefit was created in 1982, it was intended to allow people to remain at home at end of life, because if you ask most people, about 90+% said, you know, if I'm dying, I want to be at home. Okay, absolutely. But that having been said, you can have hospice care anywhere. So people living in nursing homes, well, in essence, that's become their home, right, and they can have hospice care there. People living in assisted living can have hospice care, and in fact, they can even have hospice care, a special level called general inpatient, in a hospital setting. So in fact, anywhere patients are, you can have hospice care.
Okay, let's talk a little bit about some of the myths surrounding hospice care, and I have a list of myths versus facts, and I'll read them off, and you tell me, is it a myth or is it a fact? Hospice is where you go when there's nothing more that your doctor can do for you.
Well, unfortunately, many people hear this from their doctors, and they say, I'm really sorry, Mrs. Smith, there's nothing more I can do for you. In fact, there is always something that can be done for every patient, right, to the moment that they die. And so what hospice is going beyond the point where most doctors are trained to go. Most doctors are trained to diagnose and treat illness. But what happens when it's untreatable? They're not particularly well trained in pain and symptom management. When you talked about my board certification, I have special training in pain and symptom management. Right. And so this idea that when there's nothing else to do is really not, is a myth.
The next item I have here is that good care at the end of life is extremely expensive.
Quite the contrary. What's been shown unequivocally is that people, the Medicare, people who access their hospice benefit it costs much less to provide care to them. It saves Medicare a huge amount of money. The statistics are actually staggering. That if you look at, and you talk about Medicare and the cost of Medicare, and what it turns out is that 29% of all money spent on Medicare is spent in the final 1 year of people's lives. Now, people are on Medicare now 15, 20, 30 years, and yet literally almost a third of all the money spent on them is spent in that final year of life. And if you look at the final month of life, it's 9%. Wow. So we spend 9% of all Medicare dollars in the final 1 month of life. So in fact, you know, this is a very strong argument for referrals to hospice from a financial perspective.
The next comment I have is hospice is only for the last few days of life.
Absolutely not. Unfortunately, and we do get a lot of very late referrals, and unfortunately, when those occur, all we can do is crisis intervention. Now, are we good at crisis intervention? No one's better than we are, but it is said that for people to benefit maximally from what hospice has to offer, that they need at least 2 to 3 months on hospice. Because let's face it, I can walk in and I can show them my name tag and I can say I'm the medical director of All Care Hospice, and people might say, well, he's probably a pretty good guy because he's the medical director of a hospice. But between you and I, if you're going to trust people to care for you at end of life, you want to know who these people are.
Absolutely.
You want to have a relationship. And you, in crisis, at the end, the last few hours, few days of life, there's no time to establish relationships. So we do our best work when we have more time. And so it's really my advice to people that if you even think hospice might be appropriate, it's the time to ask for a hospice consult. The worst that could happen, we could say you're not quite ready for it or you don't quite meet the criteria. But people who do qualify, anyone between you and I who doesn't take advantage of this extraordinary benefit, you know, who qualify, they're really missing the boat.
Now, is it fair to say that you need a medical doctor's referral to hospice? A person can't just pick up the phone and call hospice and say, I'd like to be a patient? Interestingly,
what it requires to get on hospice, there has to be a referral from a doctor. And then once that person is referred to hospice, the medical director of that hospice has to concur that they're hospice appropriate. But I will share with you that when you look at who initiates the referral, okay, that only 15% of the time does the doctor actually say to the family, the patient, we should refer you to hospice. And 85% of the time, it's coming from the family, it's coming from nurses caring for that patient, the VNA, it's coming from everyone else. And oftentimes, doctors, I think because they still have the misconception that, you know, this is only for the end, and they say, oh, they're not ready for hospice. And that's really, most of the time, it's a mistake.
Does hospice also represent some form of respite for the family care providers?
Well, interestingly, and I can't go into the 4 benefits that hospice provides, but one of them is a respite benefit. And under the respite benefit, a family, say they want to keep a loved one home, but they're exhausted. They've been caring for them for a long time. This often happens with families who've been caring for someone with dementia. And they say, I'm exhausted, I can't do it anymore. Under the respite benefit, on a regular basis, and it doesn't say how often, the patient can be placed in a nursing home for 5 days to give the family time off. And they can sleep, they can watch videos, they can go to Bermuda. Okay, but so on a and we have particularly families who have been caring for people with dementia on a very regular basis. Once a month, they'll get 5 days off.
Wow.
It's pretty cool.
Wow. That is.
Yeah.
I actually didn't know that.
Yep.
Another comment that I have here is that hospice is only for cancer or AIDS patients.
Absolutely incorrect. Hospice is for anybody with a terminal illness. In fact, in a mature hospice, one that's been around for a while, typically cancer patients represent a minority of the cases we care for. So at All Care, I would say in any given day, typically 60% of our patients do not have a diagnosis of cancer. Okay, Alzheimer's dementia is a very common reason why people are referred to hospice. Heart disease, lung disease, liver disease, kidney disease, all non-malignant disease. So anyone with a progressive terminal illness is eligible for hospice.
Okay, well, it's interesting you say that because the next comment I have here is hospice only focuses on the dying process.
Well, you know what I always say? is, well, it's just a total misconception that I find hospice work extraordinarily life-affirming, because hospice, really the focus of our care, unless the patient is referred in the last few days or hours of their life, when all we can focus on is how do we get them through that transition comfortably with dignity. But when appropriate referrals are made, most of the time and energy spent by the members of a hospice team providing care to that patient and family is not about death and dying, it's about life. And it's how do you take people who are terminally ill, and how do you maximize the quality of their life for as long as is humanly possible. And as we talked about earlier, in fact, they're more likely to live longer. So the focus of hospice care is not death and dying. It's not depressing. It's incredibly life-affirming, because between you and I, everybody should recognize that here but for the grace of God go we, and that what we should do is live each day to its fullest. And that's what hospice is about.
At any age.
Yeah, at any age and under any circumstances.
And at any age, it's also all about quality of life.
Yes,
We all want to live a good quality of life.
Absolutely.
I think that's a great place for us to start.
Okay.
Today, we navigated the world of hospice and palliative care. We learned that as Americans live increasingly longer lives, many struggle with age-related illness and/or disability. For these older adults, there are many healthcare choices, such as nursing homes, assisted living facilities, adult daycare, home health nursing agencies, home care agencies, and hospice care. Which one is most appropriate for your loved one? Only you can choose what's right. As regards hospice, it's a philosophy of care providing medical, emotional, and spiritual care focusing on comfort and quality of life. Today we learned from Dr. Hays that the goal of all care hospice is to enhance the quality of a person's life while optimizing the time spent with family and friends. In this regard, All Care Hospice offers support to patients, their families, and friends while striving to cope with the difficult decisions and questions regarding end-of-life care. Therefore, it is important to remember that hospice offers families both professional support and training to care for loved ones. Before you choose a hospice care agency, do your homework. Talk with your loved one's physician and ask many questions to determine whether hospice or palliative care services will provide your loved one with the appropriate level of care and comfort. As always, educate yourself so that you become more aware about hospice and palliative care. Learn which of these types of care is most appropriate, understanding that although hospice maintains quality of care for terminally ill persons and their families, it is not a service limited to the last few days of life or the elderly. Hospice serves anyone facing a life-limiting illness regardless of age. In some cases, hospice can stabilize a patient's medical condition and address other needs. Learn about the settings where hospice care can be given, understanding, however, that although hospice care is most often given at home, it is also given in a nursing home, assisted living facility, or a hospice residence. Also recognize that hospice care can contribute to easing the level of stress experienced by a caregiver. As regards payment for hospice services, remember that hospice is often paid for by Medicare or private health insurance plans. Remember to seek out the assistance of a skilled and experienced hospice agency employing specially trained doctors, nurses, social workers, and counselors who have a good track record of providing a high level of expert and compassionate medical care, such as All Care Hospice. Bear in mind that the best time to learn about hospice is before someone in your family is facing a healthcare crisis. For as Ben Franklin is quoted as saying, an investment in knowledge always pays the best interest. Lastly, don't forget the legal side of the equation. It is important to prepare advance directives such as durable powers of attorney and healthcare proxies. In closing, thanks to my guest, Dr. Hays of All Care Hospice, for participating in this program. And as usual, thank you to you, our viewers, for watching Your Money, Your Life. My name is Attorney Ramsey Bahrawy, building your trust.